Hi, my name is Robert Demeff. I'm a regenerative medicine physician with Texas Orthopedic Associates here in Dallas, Texas. And I'm going to talk today about platelet-rich plasma injections. Most people have heard of platelet-rich plasma injections, or PRP, because it's in the news. In treating our athletes, they go in for their PRP injections. Let me try to explain what PRP is. So if you look at blood, there's basically two components to blood. There's the plasma, which is the liquid portion, and there are the cells. And the cells include red cells, and white cells, and platelets. The red cells, as most people are aware, carry oxygen and carbon dioxide to and from the tissues. The white blood cells are part of our immune system and help fight off infections. And then the platelets are the cells that result in tissue clotting. Now, the other thing we found in the last few years of research is that these platelets also have growth factors in them, and it's these growth factors that stimulate a healing response after you've had your injury. So the first thing that happens when a person injures their body part is that a capillaries rupture, and there's bleeding into the area. And so the bleeding brings in the red cells, the white cells, and the platelets. The platelets cause the clotting, and then they start the healing response by releasing these growth factors that bring in the satellite cells and the white cells and these other cells to start the healing process that oftentimes takes a long time to recover from. So what we do with PRP is we take those blood components and we basically spin it down and separate the blood into the plasma that has the platelets in them. So now we're collecting these growth factors. Now these growth factors, there's at least 30 or more growth factors are in these platelets. And so when we inject these, what we're trying to do is to inject a lot of these platelets by concentrating them into the area that will hopefully result in a better healing response. Now nobody knows exactly the best number of platelets to have. If you draw your blood, normal is anywhere between 150,000 and 400,000 platelets. But if we multiply those by concentrating them to 3 to 5 times baseline, we seem to think that that results in a little bit better healing response for your musculoskeletal injury. There's two types of granules in the platelets. We call them alpha and dense granules, and they have different functions, and that's where these growth factors come into play. And once we inject these, most of them get activated in a very short period of time. However, they can have effects that last for maybe 7 to 10 days or longer. So these are not working for 6 weeks, but they're working for a relatively short period of time and working in the sense of stimulating the healing response. Now, what all does this include? And it's very complicated, and there's a lot of information out there, but there's a lot of information that we don't know exactly what happens with these growth factors. But they definitely, obviously, result in coagulation. They act like a little glue to hold the tissues together. They become a bioactive scaffold for the tissues to repair. They restore the extracellular matrix. They get the tissues to, again, repair the injury. There's two types of PRP that we talk about. There's leukocyte-rich and leukocyte-poor. And leukocyte just means white blood cell. So if we have an area where we want to cause inflammation, where a person's had sort of chronic tendinitis and it's just not healing, we want to put white cells there to cause inflammation. So we will do the spin cycles so that there's more white cells in there. We call that leukocyte-rich PRP. If it's an area where we want to stimulate healing, but we don't want to cause inflammation, namely into an arthritic joint, we would do the spin cycle so there's not very many white cells in there, or what we call leukocyte-poor PRP. So when you hear about doctors talking about leukocyte-rich and leukocyte-poor, that's why we make the decision in terms of doing the spin cycles. Now, interestingly, the PRP itself, while it can be extremely painful to do for certain conditions, oftentimes has an analgesic effect to it, and it's also antibacterial, so it can actually fight off infections. And so what we find is that with injections with PRP, the rates of infection are actually less than when we inject with cortisone and other compounds. So what do we know from the basic science standpoint? And there's a lot of great scientists around the country and around the world that are doing research on PRP. And a few things that we've come to appreciate in the lab, now we don't know if this actually happens in the human being, but in the lab, is that if you mix it with an anesthetic, a numbing medicine, or if you take an anti-inflammatory medicines like ibuprofen or naproxen, that will counteract the effects of the platelets. So in general, we tell people don't take anti-inflammatory medicines within a week before or a week after getting your PRP injection. Some people say 2 weeks, but that's the idea behind this. We also know from studies in the lab that if you repeat the PRP injections every 4 days, there seems to be a better cellular response. People can't afford to do PRP injections twice a week. We also know that aging does not seem to have a big impact on the platelet effects, so that the platelet effects in a 20-year-old are probably the same as the effects of the platelets from an 80-year-old. If we look at the basic science literature, the studies that have been done, there have been a lot of studies that have been done. Unfortunately, we don't have great science that absolutely supports that PRP is the end-all be-all to get tissues to repair. We do know from lots of studies on surgeries that adding PRP to the surgical case doesn't seem to result in better improvement compared to a placebo. In non-surgical cases, what we find is that PRP does seem to result in better improvement or better outcome in patients with arthritic joints, in patients who have tendinopathies where the tendons break down, like rotator cuff, tennis elbow, Achilles tendon, patellar tendon. We seem to think that whether it's the PRP or the fact that we needle the tissue, those folks seem to get a little bit better healing response than not doing the injection, or oftentimes compared to just a saline placebo injection. That being said, we definitely need more studies to figure out who the best candidates are for PRP. So how do I use PRP? I like to think of it as acute injuries and chronic injuries. So in acute injuries, with acute muscle injuries, tendon injuries, ankle sprains, joint sprains, oftentimes I'll do PRP injections a couple times a week, 2 or 3 times a week for 2 to 3 weeks. But because it's expensive, we generally reserve this for the high-level athletes who got to get back on the playing field very, very quickly. Most of the time when people do PRP, we do it for more chronic problems, things like osteoarthritis, tendon tears and tendon ruptures, sort of chronic rotator cuff tears, tennis elbow, hip tendinitis, or bursitis as people call it, Achilles tendinitis, plantar fasciitis. In those situations where there's not great healing, if we inject platelet-rich plasma that is leukocyte-rich, meaning white cells, we think that by needling the tissue and putting the PRP in there with white cells, that we can stimulate a healing response that results in better outcome. Most of us feel that's probably the case, although every patient responds differently. So that's a summary of platelet-rich plasma. So again, what PRP is taking the platelets in the whole blood, we spin it down and concentrate it. Those platelets have growth factors. We inject them into the area where we want to get the tissue to heal, and then coupled with all the other things we do for treatment, hopefully we get a better healing response. Thank you, and I'll refer you to the websites listed below for further information.